So the first view we begin with is the parasternal long axis. And this is what it looks like right here. For those of you who were on campus today, I got a chance to scan for you guys. This was the very first view. It's called your parasternal long axis or your Plax. And normally it starts at the fourth intercostal space, but some people it's one rib space higher than that, and others it might be one lower than that. The indicator should be turned towards the person's right shoulder, and you want to increase the depth first. The reason why we're increasing the depth is to check to see if there's pericardial effusion, pleural effusion, or any type of extracardiac mass or situations that might affect the heart. We're going to decrease the depth, and we're going to check for the chamber size, the wall thickness, and how well the heart is functioning globally, and are the valves functioning properly. So these right here are labeled. This one is the right ventricular free wall. This one is the mid-anterior septal wall. This one is number 3 is the basal anterior septal wall, or the interventricular septum. Number 4 is the basal inferior lateral wall, but most people just call this the posterior wall, honestly. This is the mid, and this is the inferior lateral. So this is the mid inferior lateral, and this is the basal inferior lateral. So the mid and the base. The base sections are always going to be closest to the valves. Now, in Plax, what you're going to see for your aortic valve leaflets are your right coronary cusp and your non-coronary cusp. This is showing you your anterior mitral valve leaflet, your posterior mitral valve leaflet, your chordae tendineae, and your papillary muscles. If you want to look at it with this live image, this is your right coronary cusp, your non-coronary cusp, your anterior mitral valve leaflet, your posterior mitral valve leaflet, a little bit of the chordae tendineae right here, and you can see the papillary muscles coming in right here. So we take a grayscale image of this on a video clip. Eventually we will get an end-diastolic measurement and an end-systolic measurement. So let's talk about the 2D measurements that we do. So when we're looking at the long axis or the parasternal long axis left ventricle and the long axis aorta, these are some of the measurements that we will do. You will do your right ventricular free wall measurement. I actually don't like to measure it here because it's more accurate in subcostal, so I probably wouldn't measure it here. You'll measure your right ventricle, and this measurement should be done at the largest dimension separately from the rest of your measurements, and you're measuring it in end-diastole. That's when the ventricles are the largest. Then the next thing you're going to do is 3 measurements. You're going to measure your interventricular septum. This is all in end-diastole, when the ventricles are the largest. Your walls should be very thin at that point. The interventricular septum from here to here, your left ventricular internal dimension in diastole, which ranges from here to here, and your posterior wall thickness, which is from here to here. That's your end-diastole. In systole, you will measure your left ventricular internal dimension in systole from here to here, and you will measure your left atrium from here to here. But the left atrial measurement should be done leading edge to leading edge. The rest of these are inner edge to inner edge. Now let's talk about your aorta. So you would measure your LVOT diameter right here, and you measure that in mid-systole. You also measure your aortic valve annulus in mid-systole. Then we are back in end-diastole. You're going to make 3 measurements here. You're going to measure your sinus of Valsalva right here. You're going to measure your sinotubular junction right here, and your ascending aorta right here. All of these are leading edge to leading edge measurements. Remember to start your study at the parasternal window, always around again that 4th intercostal space, and you want the transducer to be turned towards the patient's right side. So ultimately, we're going to be measuring all of these before we move on. So the reason why you're taking this end-diastolic measurement and the end-systolic measurement right here is so we can get what is called an ejection fraction. So what the ejection fraction is, it is the percentage of blood that the heart pumps out every single beat. So again, the EF is a measurement of how much blood is pumped out of the left ventricular chamber every time the heart contracts. If your heart is functioning over 70%, they will say it's high function. Normal is between 55 to 70. Low is from 40 to 55. And you might have serious heart issues if it's less than 40. The doctors actually care when it's less than 35. And 25%, you should definitely let the doctor know immediately. After you've done this job for a while, you'll be able to estimate the ejection fraction just by you being good at what you do. And over time, you would have seen it so much that you can tell when it's normal versus when it's not. The Teichholz method is the linear method that we did in Plax just now, where you measured all those lines in end-diastole and end-systole. The biplane method of disc summation, for those of you who are in lab, you saw me measure that today. It's a measurement that is in apical four-chamber. You take the end-diastolic measurement and subtract the end-systolic measurement, and it gives you what your ejection fraction is. Just so you know, the biplane method is preferred over the Teichholz method currently. So this RV anterior wall right here, it should be thin, it should squeeze concentrically, and in end-diastole, your RV wall should be between 0.1 to 0.5 centimeters or 1 and 5 millimeters. If it's greater than 5 millimeters, it's exceptionally thick. We don't want that. Remember a few things though. The right ventricle is the most anterior chamber. It's going to be smaller than your left ventricle. It's going to have a bit of a crescent shape and shape to it, and sometimes you'll have a moderator band. So you'll see, again, not all the time. If you have a moderator band, it'll show up on the right side. And what a moderator band is, it's a muscular band of heart tissue that is found in the right ventricle of the heart. If you want to find out a little bit more about it, it's on page 67, page 68, and I believe page 69 of your book. Keep that in mind. Now, every place you work is going to have their own protocol. Make sure that you go by that place's protocol, and when you start working and doing echo long enough, you will have your own protocol. All right, so in long axis, you want to get the LV dimensions, and you want them to be perpendicular to the actual heart view. When you are doing color flow, you want it to be parallel. When you're doing dimensions and you're measuring structures, you want the structure to be perpendicular. You want your measurements to be perpendicular to the cardiac structure. So in a straight line, and immediately below the tips of that mitral valve leaflet, that's where you're going to measure your LV. So interventricular septum, your LV, and your posterior wall thickness. Make sure that you measure them. Now, when you get to, for your interventricular septum and your inferior lateral wall, the ratio should be 1 to 1, meaning if this is 0.6, if it's normal, this should be about 0.6 to 0.7. They're going to be thicker than the right ventricular walls. They're going to squeeze concentrically, and every once in a while you'll meet somebody that has what we call a sigmoid septum. That's this thing right here. Remember, not everybody is going to have this. So this big arrow that's showing the sigmoid septum, as you get older, you may form the sigmoid septum. You do not want to measure this when you, as part of your interventricular septum measurement. We don't want that. So the vertical arrow that you're seeing right here is an left ventricular false tendon. It's a cord-like structure, but it'll never be attached to a valve, just so you know. It's usually attached to like the septum and the papillary and the free wall, but it's never going to be attached to a valve. That's what you need to remember about that. Now, when it comes to these measurements, women and men have different numbers, but I don't want you to worry about those numbers right now. Just know that you're going to measure the interventricular septum, the left ventricle, and the posterior wall thickness in diastole. Then you're going to measure the left ventricle in systole, and you're also going to measure the left atrium in end systole. End systole. Remember that. So I'm going to talk about this sigmoid septum right here. So if you're doing this end diastolic measurement, you're going to do this. If they have a sigmoid septum right here, move back a little further and measure your dimensions right here, and then measure the sigmoid septum separately. So you're going to want it to look like this. So right past that sigmoid septum right here is where you're going to measure the interventricular septum, the left ventricle, and the posterior wall. And then you'll measure this separately, because you might give the person hypertrophy or thickened walls if you measure the septum, or I'm sorry, the sigmoid septum, as opposed to the actual interventricular septal wall, which is right here. I kind of just wanted to pull your attention to that. Anything over 1 centimeter or 10 millimeters is considered hypertrophy for both men and women. So we don't want that. Now, left ventricular hypertrophy is something we don't want, but eventually you're going to run into it. So this is somebody that has an extremely thick, they have concentric left ventricular hypertrophy. Look at how thick the walls are. So let's go back a little bit. And I just kind of wanted to show you a regular wall. Remember this? See how this is not anywhere close to as thick as the other little clip that I just showed you guys. Now let's go back to that other clip. Look at how thick this wall is. So here are your measurements. For men, it's, by the way, I use centimeters instead of millimeters. So you just move the decimal point 1 place over to the left. So 0.6 to 1 centimeters is normal. 1.1 to 1.3 centimeters is mild hypertrophy. 1.4 to 1.6 is moderate. Anything greater than 1.7 is severe left ventricular hypertrophy. For women, 0.6 to 0.9 centimeters is normal. 1.0 to 1.2 is mild. 1.3 to 1.5 is moderate. And anything over 1.6 is severe hypertrophy. You should know that. So for example, if the interventricular septum and the posterior wall thickness both measure 15 millimeters for a man or a woman, you would say they have moderate concentric left ventricular hypertrophy. All right, so you would then, once you get your end diastolic and end systolic measurement, you're going to zoom into that aortic valve. And you want that LVOT, that's the left ventricular outflow tract that leads out into the aorta. You want it to be unobstructed. You want the flow to be laminar. That is flow, like steady flow state that's not disturbed or have any type of turbulence. You'll zoom in, and in mid-systole is where you'll measure that LVOT. You want it to be between 18 and 22 millimeters. Now, again, you're acquiring this in mid-systole. And you want it to be in the parasternal long axis. You want it to be zoomed. You're measuring it inner edge to inner edge. And you want it to be parallel and next to the aortic valve. Just keep that in mind. Gonna repeat this. You're measuring this in mid-systole when the valves are completely open while the blood is still leaving, and you want it to be inner edge to inner edge. So from the inner edge of the septal endocardium to the inner edge of the anterior mitral valve leaflet. So you want it to be probably within 5 to 10 millimeters of that aortic opening, all right? Now, let's now talk about your mitral valve. So this blue line right here, you need to know that the mitral valve closes before, like ahead of that mitral annular plane, and it should never bow back into the atrium If it does, we call it a mitral valve prolapse, like a parachute when it's closed. It shouldn't look like that ever. So this is your anterior mitral valve leaflet, and this is your posterior mitral valve leaflet. This is your right coronary cusp, and this is your non-coronary cusp. Now, your anterior mitral valve leaflet and your posterior mitral valve leaflet should be thin, and they should be pliable. They should open properly without any issues. The opening should not be restricted. Your anterior mitral valve leaflet is going to be larger and more mobile, and you want it to be continuous with that aortic root. So the anterior mitral valve leaflet right here should be continuous with the aortic root, which is right here. It should close before the annular plane. This is that imaginary blue line that you're drawing. That's the annular plane. If it closes and bows back in, it means the person has what we call mitral valve prolapse. The left atrium should be smaller than the left ventricle. And the size of that left atrium is going to depend on the gender and the person's body surface area. So we're going to measure this measurement for the left atrium in end systole, and we want it to be leading edge to leading edge. Just keep that in mind. Do not worry about the numbers. So in apical four-chamber, we will end up measuring LA volume, but we will talk about that separately when we get to the four-chamber. So let's talk about a few different things like a flail mitral valve and all that. I want to show you some images right here. Remember that imaginary annular plane? So when the mitral valve closes, it should look like this. It should not bow back in. So it could balloon out right here if the person is starting to have an issue with the valve. You can have a posterior mitral valve prolapse. That's this imaginary line that you've drawn with your eye. Notice that the anterior mitral valve is still above it, but the posterior mitral valve has bowed in. This is what prolapse is, where there's a bowing in from here to here and from here to here, instead of closing like this one does on the other side of this imaginary line. You can have a flail mitral valve leaflet as well. And what that is it's where the leaflets fail to close properly with rapid systolic movement of the leaflet into the left atrium. But usually the reason why you have a flail mitral valve is due to like a rupture in the chordae tendineae, the cords that hold the mitral or the leaflets open, or like a papillary muscle like fracture or like a disconnect. So it could result in acute or subacute like chronic mitral regurgitation. This can't go on, otherwise the person is going to have severe issues later on. So this has to be fixed right away. All right, so we eventually are going to zoom in on the mitral valve and make sure that it looks good. You're going to see a descending aorta, and you're going to sometimes see your coronary sinus. So the coronary sinus is up here. This is your descending aorta. This is your coronary sinus. Now, sometimes the coronary sinus can get big and look kind of like a descending aorta, but the only time you see it is if your coronary sinus is dilated, like let's say it is like right here. Normally it'll measure 4 to 10 millimeters, and if it's dilated, it indicates that the person has right ventricular dysfunction or like increased right atrial pressure, or the person has that persistent left superior vena cava. We'll talk about that much later. But what it is it's a common variant where superior vena cava drains into the coronary sinus behind the left atrium, which causes the coronary sinus to become dilated. So then the coronary sinus is now going to drain directly into the right atrium. So this is why they won't worry about it. It won't cause any problems. It just means that the person is going to have that dilated coronary sinus. So we can't finish Plax without doing what we call M mode. This is what M mode looks like. So the first thing you're gonna do is gonna run the cursor over the aortic valve. Then you're gonna run it over the mitral valve, and it's gonna look like an M right here. And then you're gonna run it over the ventricles, and it's going to look like this or this right here. Try not to get these choppy images. Make sure they look smooth like this. And this arrow right here is showing continuity from the posterior to on the posterior aortic root wall to like that anterior mitral valve leaflet. Don't worry about M mode. We don't measure in it anymore. We want it to look like a continuous strip though. Just keep that in mind. And it shows us the timing of the cardiac cycle. That's why we still use it. We don't measure in it, but we still show it. Page 73 does a really good job of explaining. Now I want to talk about color flow Doppler in Plax. So if a person had mitral regurgitation or any type of regurgitation with the aortic valve or mitral, you will first notice it in Plax. So you're going to use color flow Doppler on the aortic valve, on the interventricular septum, on the LVOT, the left atrium, and the mitral valve. So these are frozen images from your book, but I wanted you to see what a live video clip would look like. So you're going to have an off-axis image sometimes where you may not get the full jet. Sometimes if you have to go off-axis to make it better, do that. And other times, if you're not correctly on axis, you're not going to see everything you need to see. So if you can, whatever you need to do to improve the Doppler angle to locate any type of eccentric jet, including going off-axis to show that, do that. So let's say you did this and you saw very little mitral regurgitation here, but then you went slightly off axis and you see it much better here. This is much better for the doctor than anything else that you would have done for him today. So now, we're back to these measurements that I mentioned earlier. So in long axis, you want to zoom in on that aortic valve or the aorta, and the image is going to look like this. So what you're going to see is your right coronary cusp and your non-coronary cusp, your sinus of Valsalva, and that's where you'll measure your aortic root, your sinotubular junction, and the proximal ascending aorta. Make sure that these are all leading edge to leading edge, not inner edge to inner edge, but leading edge to leading edge. Do you see this diagram right here? They're done in end-diastole, leading edge to leading edge. So your aortic valve annulus diameter, this should be measured in mid-systole before you get, just before you get to the aorta. Don't worry about the numbers for now. Just worry about what it looks like and where to measure it. The sinus of Valsalva, that's this structure right here. This is where you measure your aortic root. The sinotubular junction is right here, and the proximal ascending aorta is right here. Now, for everything aorta related, 3 centimeters or less is considered normal. 3.1 to 3.9 is considered dilated, obviously with 3.9 being extremely dilated. Anything over a 4.0 we call an aneurysm immediately. You always want to call to attention whenever you see an aneurysm, let the doctor know immediately so they can figure out something about it. And also inform the patient. You don't inform the patient, the doctor informs the patient. So once you're done with that, you're going to go to the long axis RVIT. So you're going to angle medial and inferior from the long axis or the parasternal long axis. You're going to angle towards the patient's right hip. So when you angle towards the patient's right hip, you're going to be seeing the anterior and inferior RV walls. Now, reason why we do this is to show the valves and show if the person has regurgitation. So you can have what's called the, no, I don't want to talk about that. I'll talk about that later. By the way, this is a eustachian valve right here. Not everybody has it. It's like a remnant of the valve closure when you're born. You don't use it as an adult though. So this is your coronary sinus, this is your inferior vena cava, your superior vena cava, your right atrium, your right ventricle, and again, this is a eustachian valve. So just keep that in mind. And these numbers right here matches up with these right here. So whenever you're going back through the PowerPoint, I want you to make sure you memorize these because I may test you on these in lab. So the last thing I want to talk about is when we do that RVIT and we are angling towards the patient's right hip, what we're looking for is to see if the person has tricuspid regurgitation. So we use color flow Doppler as they do right here, and we're going to put it over that tricuspid valve. So what you're going to see is the right ventricle, right ventricle, tricuspid valve, right atrium, and some TR if they have it. Up to 93% of the world's population has trace to mild tricuspid regurgitation. And what we want is that RV inflow pattern. So we could use a pulse wave at the gates and the tips of the mitral valve. You don't have to. Most people just use continuous wave Doppler. And the continuous wave tells you if the person has tricuspid regurgitation. So if they do, you measure it right here. It's going to give you a number. We'll talk about that much later, but that number is going to be put into a formula, and then you add other numbers to it to get what the right ventricular systolic pressure is, or the pulmonary artery systolic pressure. Don't worry about that for now. Right now, just know that we get an RVIT image, and we use continuous wave Doppler most commonly. You could use pulse wave Doppler, but not many places I know actually even focus on that. For now, this is where I'm going to stop for today.